Okay, so let's look at disorders of menstruation. So these are examples of the common menstrual problems. Basically, problems with the volume, it could be scanty or excessive. Problems of irregularity, that's too frequent, infrequent, or unpredictable when it would come. And problems of pain, the absence, associated symptoms. And also problems with the bleeding and also in between periods. So the various terminologies that we use are menorrhagia. I'll talk about the rest later. So menorrhagia basically refers to prolonged menstrual bleeding that is excessive in amount, duration, or both, and that occurs at regular intervals. Also, we have heavy menstrual bleeding. That is a modern term. We also have metrorrhagia. That's basically menstrual bleeding occurring at intervals, irregular intervals. That is normal in amount and may or may not be prolonged. And we have polymenorrhea. That's a menstrual cycle interval of less than 21 days interval. Hypomenorrhea basically refers to scanty menstrual period. So menorrhagia, that's heavy menstrual bleeding. Metrorrhagia, menstruation or menstrual bleeding occurring at irregular intervals, maybe prolonged or normal. We have polymenorrhea and hypomenorrhea. Okay, so remember these terms. We have menometrorrhagia. I said metrorrhagia, menstrual bleeding occurring at irregular intervals, may be normal in amount or may not be, may or may not be prolonged. But menometrorrhagia is prolonged menses with intermenstrual bleeding. Okay. And amenorrhea, like we already know, absence of menstruation of more than 6 months or 3 normal cycles. Like we discussed, we have the primary, that's less than 14 years, that's they've never been pregnant before, they've never had their menses before, that's basically their primary amenorrhea. A secondary is when there's absence of menstruation of more than 6 months or 3 normal cycles. Oligomenorrhea has menstrual cycle interval of more than 35 days, and dysmenorrhea has painful menstruation. Post-menopausal bleeding, that's bleeding from the genital tract occurring more than 12 months after the last menstrual period of a menopausal woman. Okay, so let's look at another term, which is dysfunctional uterine bleeding. Okay, so abnormal uterine bleeding or dysfunctional uterine bleeding is uterine bleeding that occurs in the absence of identifiable pathology. So dysfunctional uterine bleeding is basically abnormal uterine bleeding occurring in the absence of identifiable pathology, and it's subdivided into ovulatory dysfunctional uterine bleeding and anovulatory dysfunctional uterine bleeding, and it's a diagnosis of exclusion. Okay, so let's go back and revise that of the normal menstrual cycle. So menstruation has 3 clinical demarcations of phases, and we have the menstrual interval cycle, the flow duration, and also the amount of flow. Okay, so the mean cycle length is 28 to 29 days, although menstrual interval is 21 to 35 days. And this from 21 to 35 days is considered to be normal. Duration or flow duration is normally 7 days or less. In abnormal uterine bleeding, there's an alteration in the normal pattern of menstrual flow, and these abnormalities include excessive flow, like we talked about, prolonged flow, spotting, and intermenstrual bleeding. And for the differential diagnosis of abnormal uterine bleeding, you take into consideration the age of the patient, whether it's menarche or menarchal reproductive age range or peri or post-menopausal age range. Okay, so abnormal uterine bleeding in children could be just physiologic, could be from an infection, vaginitis, foreign body trauma, including sexual abuse, uterine prolapse, endocrine, as PCOS, from thyroid, precocious puberty, genital tract neoplasms could cause abnormal uterine bleeding in children. The common causes of abnormal uterine bleeding in adolescents, basically an ovulation could cause that, coagulopathy, pregnancy-related cause, vaginal pelvic infection, benign lesions, exogenous hormones and drugs too, and it could just be anatomic. Okay, for example, Müllerian anomaly could cause it. Other causes of abnormal uterine bleeding in reproductive years are pregnancy-related causes, anovulation, vaginal pelvic infection, pelvic tumors, uterine fibroids, endocrine, like the thyroid disorders, PCOS, exogenous hormones, for example, pre-mentrual could cause it. Also coagulopathies. Abnormal uterine bleeding in perimenopausal period. We have anovulation, uterine fibroids, adenomyomas, adenomyosis, cervical lesions, endometrial hyperplasia or endometrial cancers, and also endometrial polyps could lead to abnormal uterine bleeding in perimenopausal period. For menopausal women, it could be cervical malignancies, endometrial hyperplasia, endometrial carcinomas, endometrial polyp, atrophic changes, and uterine fibroids too. Also, HRTs could cause that. The conditions associated with anovulation and abnormal bleeding, we have eating disorders, like anorexia nervosa, also bulimia, excessive physical exercise, chronic illness, stress, thyroid disease, diabetes mellitus, androgen excess syndromes. Abnormal uterine bleeding, we have organic and non-organic dysfunctional uterine bleeding. So for the organic causes, we have the local, systemic, like I've already said, fibroids, adenomyosis. All these are local, structural, organic causes of it. IUCDs, PID, cervical cancer, endometrial cancer. For the systemic, it will be from thyroid disease like diabetes mellitus, adrenal, hyperprolactinemia, liver dysfunction, renal dysfunction, and drugs. And non-organic will be anovulation, ovulatory, extremes of reproductive age, 85%, common in obesity, and also age from 35 years to 45 years, regular, heavy, painful due to a decrease in PRGs. So evaluation of a female with abnormal uterine bleeding, basically the history will tell you that the physical examination too, selected or relevant laboratory evaluation, imaging studies, usually ultrasonographic, and sonographic would help with that, with or without tissue sampling. So basically with the management, you have to start from the history. So the history, the description of the menses, the volume, duration, irregularity, and the pain to assess the severity of each of these. Look for the associated symptoms. Is there recent pelvic infection, and also the history of pelvic surgeries, any anatomic abnormalities or anomalies too. Also, previous diagnosis of chromosomal abnormalities, past history of DNC, history of post-surgical changes in menstrual flow, including Amenorrhoea and Asherman syndrome. Also, family history of any gynecological disorder, and for the gynae history to determine previous cycles and compare with the current pattern. And also contraceptive history is very important, as it may explain the current complication. For example, IUCDs and medications, we ask about and tablets like exogenous hormones to dietary history, recent weight gain or weight loss. The examination, is there a need for resuscitation? If yes, you just stabilize that first before you take the history. You get your IV assessed, you take blood for HB grouping and cross matching, give crystal oils and blood if as necessary. In a full physical examination, look out for stigmata of any systemic disease, especially endocrine disorders too. And look out for pelvic and abdominal organ enlargement. For pelvic examinations, pass a speculum to look for bleeding, infection, trauma, polyps, local lesions of the cervix. Do a bi-manual examination to assess uterine and adnexal enlargement as well as tenderness. For your investigations, you should be guided by the history and the physical examination to reduce the cost of urine pregnancy tests in reproductive regimen, FAC, full blood count to define the anemia, the blood grouping and rhesus factor, other tests that may be done if the history exams is direct, like pap smear, diagnose any suspicious lesion, cervical cultures, thyroid function tests, liver functions, renal function tests, prolactin, coagulation tests, follicle stimulating hormone, utilizing hormone, androgens, if PCOS is suspected. That's polycystic ovarian syndrome. So the investigations, you can do imaging studies. Okay, so trans-abdominal or transvaginal to define the pelvic structures too, and do saline infusion sonography, CT scan, which gives a better quality medicine. Is usually if malignancy is suspected. Also, ultrasonography is usually sufficient. Endometrial biopsy is important in perimenopausal period from 35 to 48 years. And hysteroscopically directed biopsy may be done in the proliferative phase of the cycle if available. The treatment depends on the cause and is dictated by the history, the physical examination, and laboratory imaging studies too. So the pregnancy-related abnormal uterine bleeding, normally you could do an EOU or MVA or DNC as the case may be, or laparotomy if it's ectopic pregnancy. For uterine fibroids, myomectomy or hysterectomy or conservative management. For polyps, polypectomy, infections, endometritis or cervicitis, and antibodies. For endometrial hyperplasia, it depends whether it's with atypia or not, and whether atypia, progestin can be tried for a period, and DD and C repeated. With atypia, you consider hysterectomy if she has finished with family size. Okay. For primary dysmenorrhea, just give NSAID or combined oral contraceptive pills or transcutaneous electrical nerve stimulation TENS, as we normally don't do this though. For secondary dysmenorrhea, you just treat the cause. If fibroid, you just do a myomectomy or hysterectomy. Infection, you treat with antibiotics. For intrauterine contraceptive devices associated with bleeding, and you give NSAIDs, you observe for 6 months, and if anticoagulants are high, it should be adjusted. For premenopausal syndrome, this is basically a cyclical presence of somatic, psychological, and emotional symptoms that worsen as menses approaches and are ameliorated by the onset of menstrual flow. Nearly all women with regular cycles do experience some form of symptoms or of this PM, the premenstrual syndrome, and the normally about 5% of them are very, very debilitating. More than 150 symptoms have been linked to premenstrual syndrome, and the common symptoms are bloating, mastalgia, cyclic weight gain, abnormal abdominal pains or cramps, fatigue, headache, depression, irritability. The criteria of premenstrual syndrome is cyclic and occurs in the second half of the cycle. The symptoms increase in severity as the cycle progresses, and the symptoms are relieved with the onset of menses and absent by day 3 of flow. There may be post-menstrual pain-free period for at least 7 days. The secondary amenorrhea, this usually excludes congenital genital tract abnormalities such as Amenorrhoea syndrome and imperforate hymen too. So normal menses requires intact hypothalamic pituitary ovarian axis and also patent genital tract. The absence of menses should prompt for the search of the cause in one of these areas. The causes of secondary amenorrhea could be physiologic, pregnancy, lactation, menopause, or surgical, like oophorectomy or total abdominal hysterectomies. Could be pathologic, ovarian or pituitary for pituitaries, like hyperprolactinemia, pituitary adenoma, Sheehan syndrome. For ovarian, could be gonadal dysgenesis, premature ovarian failure, pure gonadal dysgenesis, and also could be central nervous system related, like hypothalamic amenorrhea, brain injury, tumors, inflammatory or infiltrative process. Other endocrinopathies include hypothyroidism, Cushing syndrome, adult onset CAH, and diabetes. On secondary amenorrhea, the initial visit to exclude pregnancy, exclude outflow tract abnormalities, follicle stimulating hormone, prolactin, TSH issues too. Okay, they do an ultrasound scan, HSG or hysteroscopy too to help find the cause. With treatment, you treat according to the cause found on evaluation. The generalized investigation include FBC, urinalysis, sickling, blood grouping, and rhesus factor. Specific investigations would vary depending on the findings in the history and physical examination. For post-menopausal bleeding, is a bleeding after 6 months of cessation of the menses in a woman in a perimenopausal period. The bleeding should be assumed to be caused by malignancy until proven otherwise. That's postmenopausal bleeding. Inspect the genital tract. So inspection of the genital tract is mandatory in such a case, and biopsy of the lesion, if present, the pap smear, DDNC should be done. Postmenopausal bleeding, the cause of the bleeding is basically treated if it's a malignancy or a malignant lesion. That includes a multidisciplinary care. If a benign polyp, either polypectomy. If atrophic changes, short course of estrogen therapy, and if pre-malignant condition of the cervix or endometrium, either conservative or approach or surgery depending on the rates of progression.